Hello. I'm going to speak about the evolution of drug solubility and kinetics from ether to xenon. Blood gas partition coefficients are the key to understanding the differences among our inhaled anesthetics. The blood gas partition coefficient, lambda sub blood gas, also called the blood gas solubility ratio, the blood gas solubility, just plain solubility, and abbreviated this way. All of them are the same, and I will use them interchangeably as often as done. When we look at the partition coefficients or solubilities of our drugs from 1846, when the introduction of ether, all the way to very recent years of modern anesthetics and xenon possibly coming in the future, we see a solubility range that's quite large. We see that ether at solubility of 12 is 92 times more soluble than xenon, and it's 28 times more soluble than desflurane, an incredibly wide range of blood gas solubility. So what does blood gas solubility really do? Why is it important? Blood gas solubility determines how closely the expired tension approaches the inspired tension. How closely, not how fast. This isn't a speed thing. This is a closeness thing that may appear to change the speed of the anesthetic, but that's not what's really happening. We can see this by viewing the alveolar tension curve. I use the word tension here. Tension is partial pressure expressed in percent of one atmosphere. It's equal to the concentration of gases, but once gases get into the blood, partial pressure is a better term that's actually correct. The alveolar tension curve is the alveolar response to an inspired step. It's equal to the time course of the alveolar tension in response to the step change in the inspired tension. Let's look at that. We now have the step change in inspired in the yellow, and we're going to look at pure lung wash-in without uptake into blood. This is just drug going into the patient's lungs, and we're going to look at the alveolar response to this step change. Here we have the curve. The curve goes up rapidly at the beginning and then more slowly. This is the alveolar response to a step change, and it's an exponential curve. This exponential curve has only one characteristic, and that is its time constant, the amount of time it takes to get 63% of the way to its final value. In this case, it's 1/2 minute. That 1/2 minute comes from the physics and physiology of this. The time constant for any fully mixed system is the volume of the compartment divided by the flow going through that compartment. In this case, that volume is the FRC divided by the alveolar ventilation, or 2 liters divided by 4 liters per minute, or 1/2 minute. And that's where the lung wash-in time of 1/2 minute comes from. And it's why we typically wait 2 minutes for things to happen, allowing 4 time constants to go along to get the expired closer to the inspired anytime we are doing anything. Now let's take uptake into blood. Uptake into the blood produces an alveolar tension plateau. That is, as inspired goes up suddenly, alveolar was rising, that curve breaks off at a level dependent upon how rapidly drug is being taken away in the cardiac output, which has with the solubility of the anesthetic agent. So for drugs of high solubility like ether, this keeps us incredibly low. For drugs of low solubility like our current isoflurane, sevoflurane, and desflurane, we see it's much, much higher. And for xenon, of course, still higher. So the alveolar plateau height is measurable, and it can be measured for each of these agents. And in fact, it's 100% predictable. It's predictable in that it's 1 divided by 1 plus cardiac output times solubility divided by alveolar ventilation. This is the equation that defines the actual plateau height for each of our drugs. So each of them, for a different solubility, of course, has a different height, as one would expect. Now, venous return, this return converts this plateau into what we call the knee and the tail of the alveolar tension curve. This is when drug is brought back from the venous blood to the patient's lungs to be circulated again out in the arterial blood. And that's the tail of this curve. If we look at all of our drugs, they are really quite similar. If we look at the overlay now of the alveolar to inspired ratio in drugs from ether to xenon, we see the same characteristic curve. They all start out on that same exponential curve and then break off at levels dependent upon the solubility of the drug in blood. Now, the danger of high solubility is that increased minute ventilation deepens the anesthetic and produces an anesthetic overdose. And that's why the inhaled drug evolution is focused on producing drugs with reduced solubility in blood. Drugs with high solubility become, or actually are, more dangerous whenever ventilation is increased. Now, many of us practiced in the era of halothane. It was a wonderful drug for inhalation induction in children, but now and then a patient didn't survive the process. And usually it had something to do with hyperventilation at a time that wasn't expected. Let's look at a simulation of exactly that happening. Here we have in the red, so we're looking at the anesthetic partial pressure in the patient's alveoli, which is very close to that which is in the patient's brain. We see in the natural course of things when ventilation is constant, inspired is going up, expired is now coming up, and with decreased ventilation that happens naturally with halothane, we get the patient remaining at a fairly reasonable anesthetic depth. If we are ventilating the patient, however, the patient is getting deeper than that. And if we're hyperventilating the patient is getting incredibly deeper than that, leading to a significant toxicity manifest by decreased heart rate and blood pressure and all the other things that we don't see anymore in pediatric inductions now that we've abandoned that drug in most countries. We can look at something just like this and what would happen with ether. I'm going to play a simulation. Here we see two simulations about to be run. We have ether at the top and sevoflurane at the bottom. We're going to begin that anesthetic by hitting run all. And we're going to see the anesthetic levels come up to the 1 MAC level in the vessel-rich group in ether. And we get it there also in sevoflurane. Sevoflurane had a little bit of overshoot in the alveolar concentration. Ether did not. We can see that on these two curves as well. At this point, I'm turning down the vaporizer to a more reasonable value and continuing the simulation. So with the vaporizer setting lower than it was before, we've got the patient at a constant depth of anesthesia. And notice the large gap between the inspired or vaporizer concentration and the alveolar concentration for ether, because it is so very soluble. Now, at this point, we ask ourselves the question, is there any danger of this high solubility? Is there any danger with having the inspired concentration so high compared to the expired concentration? The answer is, let's see what happens if we hyperventilate both of these patients in the middle of the anesthetic. I shall do that now. So the ventilation has gone up. The ventilation has gone up. The expired concentration of ether is going up dramatically, whereas for sevoflurane, it's remaining almost exactly constant. Any insoluble drug will have this property, and any soluble drug will have that property. If we look at the overlay, show alveolar over MAC, we see that in the case of ether, alveolar gets much, much above MAC, probably enough to cause some cardiovascular problems. Whereas with a less soluble drug, we get a very constant level in the alveolar compartment and in the vessel-rich group. So we've achieved much greater safety as we've evolved from drugs of high solubility to drugs of much, much lower solubility. From ether to isoflurane to sevoflurane to someday xenon, we really have a dramatic improvement in this particular property of these drugs. Thank you.